Kawasaki disease is a vasculitic disease in which medium sized arteries throughout the body become inflamed. It typically affects young children from 1 to 5 years old, but can sometimes affect teenagers and even adults. It's usually a self limited condition, with fever and manifestations of acute inflammation for at least 5 days, lasting for an average of 12 days without therapy. And it's not very responsive to treatment with paracetamol or ibuprofen. The most frequent and characteristic signs and symptoms, included in the diagnostic criteria, can be remembered with a mnemonic crash. First off, they might typically present with bilateral bulbar conjunctival injection, which typically starts within days of the onset of fever, and leads to photophobia, or discomfort or pain to the eyes due to light exposure. Then there's polymorphous rash, that usually starts during the first few days of illness due to sensitivity to light. A stands for lymphadenopathy, which tends to primarily involve the anterior cervical nodes overlying the sternocleidomastoid muscles. Next up, there are oral mucous membrane changes, including injected or fissured lips, injected pharynx, or strawberry tongue. And finally, there are peripheral extremity changes, including erythema of palms or soles, edema of hands or feet, and periungual desquamation. To make a diagnosis of Kawasaki, individuals must meet at least 4 of these features. Other common features include irritability, rhinorrhea, cough, vomiting, diarrhea, abdominal pain, and joint pain. A severe complication of Kawasaki disease is cardiovascular disease, which most commonly presents as coronary artery aneurysms and can lead to arrhythmias, myocardial infarction, and ultimately heart failure. Typically, an ECG and echocardiogram are done in individuals with Kawasaki to look for cardiovascular involvement. On rare occasion, if echocardiography isn't available to image the coronary arteries, computed tomographic angiography or magnetic resonance angiography can be used instead. Individuals with coronary aneurysms have to undergo stress testing to evaluate for myocardial perfusion and inducible ischemia, which measures the heart's ability to respond to increased stress or demand in a controlled setting. The stress is induced by exercise, which is preferred, or with the medication dobutamine. Some children are suspected of having Kawasaki disease when they have an unexplained fever for at least 5 days, even if they have only 2 or 3 of the diagnostic criteria. That's because these children might have incomplete or atypical Kawasaki disease. This is also true of infants less than 6 months of age with unexplained fever for at least 7 days, even without any of the clinical findings of Kawasaki disease. That's important because infants are at a greater risk for cardiovascular disease. The criteria to diagnose incomplete Kawasaki include a CRP above 3 mg per deciliter and ESR above 40 mm per hour, along with 3 or more abnormal supplemental laboratory findings, or abnormal echocardiography. The supplementary blood tests include a white blood cell count above 15,000 cells per microliter, platelet cell count above 450,000 cells per microliter, normocytic normochromic anemia for age, an elevated serum alanine aminotransferase above 50 units per liter, or a serum albumin level below 3 grams per deciliter. Another supplementary finding is pyuria, having more than 10 white blood cells per high-powered field on urine microscopy. For management, individuals with Kawasaki disease should get a single dose of IVIG, 2 grams per kilogram over 8 to 12 hours, administered within the first 10 days of illness, before aneurysms typically develop. IVIG should be administered even beyond this 10-day window in individuals with evidence of persistent vasculitis or systemic inflammation, such as persistent fever and laboratory markers like an elevated ESR and CRP. In addition, individuals should get aspirin during the acute phase of illness to prevent blood clots from forming. Giving a total daily aspirin dose of 30 to 50 milligrams per kilogram per day in 4 doses while the fever lasts, and then is continued 48 hours after the resolution of fever at a low dose of 3 to 5 milligrams per kilogram per day, until laboratory markers return to normal, which usually takes about 2 months. Unless there's coronary artery involvement, in which case low-dose aspirin therapy is continued. Except for Kawasaki disease and a few other indications, aspirin is otherwise normally not recommended for children due to its association with Reye syndrome, which is a rapidly progressive encephalopathy. Because children with Kawasaki disease will be on aspirin for a long time, vaccination against varicella and influenza is required, because these infections are the ones that are most likely to cause Reye syndrome. Importantly, varicella vaccine should be postponed until at least 11 months after the IVIG has been given, because it can interfere with vaccine immunogenicity. Now, if a child has a persistent fever even 24 hours after completion of initial therapy, or becomes afebrile and then develops a fever without an alternative source within the 2-week window after initial therapy, then that's considered refractory Kawasaki disease. Refractory Kawasaki disease can put individuals at higher risk for cardiovascular disease. Risk factors for failing to respond to a single dose of IVIG include male gender, age less than 6 months, elevated CRP, and low sodium or low platelet levels. In refractory Kawasaki disease, the first step is to give another dose of IVIG, 2 grams per kilogram over 8 to 12 hours. If that doesn't work and the fevers persist, then glucocorticoids can be given. Usually it's pulse dose methylprednisolone, giving 30 milligrams per kilogram per day, given until there's a full response, or until 3 doses have been given. Alternatively, you can give a 15 to 30 day course of twice or thrice daily oral prednisone, for a total daily dose of 1 to 2 milligrams per kilogram. Since glucocorticoids can sometimes increase the risk of coronary artery aneurysm, they're only given as an adjunct to initial treatment in cases that are refractory to IVIG. Alright, as a quick recap. Kawasaki disease causes a fever for at least 5 days. In addition, they can develop bilateral bulbar conjunctival injection, a polymorphous rash due to sensitivity to sunlight, cervical lymphadenopathy, oral mucous membrane changes, including injected or fissured lips, injected pharynx or strawberry tongue, and peripheral extremity changes, including erythema of palms or soles, edema of hands or feet, and periungual desquamation. Diagnosis of Kawasaki is based on the presence of at least 4 of those features. A severe complication of Kawasaki disease is cardiovascular disease, so all affected individuals must get an ECG and echocardiography. Children suspected of having Kawasaki disease who do not fulfill diagnostic criteria might be diagnosed with atypical or incomplete Kawasaki if they present with elevated ESR and CRP plus 3 or more abnormal supplemental laboratory findings, or abnormal echocardiography. For treatment, individuals with Kawasaki disease should get a single dose of IVIG, which is 2 grams per kilogram over 8 to 12 hours, as well as aspirin, giving a total daily aspirin dose of 30 to 50 milligrams per kilogram per day in 4 divided doses, for a maximum dose of 4 grams per day, while the fever lasts. Those with refractory Kawasaki might get a second dose of IVIG, and if that doesn't work, then glucocorticoids can be given as an adjunct to initial treatment.